Thank you very much. Thank you, Claire, and thank you to CMP for this invitation. I've actually been really excited about this. I have 29 slides, which will be delivered in 25 minutes. So we're going to crack on. The Margaret Pike Trust is very unusual as an IUCN member. There's about 750,000 people in Uganda that get reproductive health services because of us, and about 3 million people in the UK get better health services every year because of training we do. And then we joined the International Union for Conservation of Nature exactly for the reason that this whole session is about, because of the connections between biodiversity conservation and human health. But our background is primarily reproductive health services. So when I talk about family planning, what do I mean? Well, I'm talking about the different methods of contraception which can be used so women and girls can decide if and when to fall pregnant, and to healthily time and space their pregnancies. Now, if you're in conservation planning or developing conservation projects, it's very common for people to talk about population issues, which we steer away from because it's a bit of a rabbit hole you don't want to go down. And instead, we always focus on barriers to family planning. And barriers to family planning are the obstacles which would prevent women and girls from accessing contraception. There's a huge diversity of them. Here's just 5 examples, and it can range from really obvious stuff like simply having an absence of services, no clinics, to stigma and myths and misconception, and then in some parts of the world, even horrendous things like parental consent restrictions. Now, what does that mean? That leads to an awful lot of terrible outcomes, social outcomes, community outcomes, things related to health and gender, and much more besides. But it also means that there's 270 million women and girls who'd like to avoid or delay pregnancy around the world, but don't have access to contraception. And the health sector think of these 270 million women and girls as the absolute priority because they just want to access contraception and they currently don't have it. So that's like the absolute or one of the real priorities. And as anyone working in the health sector would know, almost invariably, health services are worse in rural areas. And a lot of the time, people on this call who are developing conservation projects are obviously working in rural areas. So there's a very interesting overlap of the geography of where both health and conservation organizations work. Now, we do a lot of work in health policy processes, as you can imagine. And then we would be talking about all sorts of other negative outcomes from barriers to family planning. But just to sort of mark one now that we would say to you that we wouldn't be talking about at a health conference, obviously, lots of people involved in conservation projects would want women to be able to retain their alternative and sustainable livelihoods. Now, back in Marseille at the last World Conservation Congress, we got a coalition of 18 IUCN members together and then passed a motion titled "The Importance for the Conservation of Nature of Removing Barriers to Rights-Based and Voluntary Family Planning." This was the first motion that had ever passed and even slightly within this topic at World Congress. That led to the creation of the Biodiversity and Family Planning Task Force, which I'm proud to co-chair with my colleague, Corina Hirsch, who isn't here, so I'm covering for her. And the motion had 3 other core asks of IUCN. And that was to include reproductive health in national plans under the Convention on Biological Diversity, training on conservationists on reproductive health, which sort of includes something that we're doing today, and then promoting PHE projects, which is population health environment programs, and where the Conservation Measures Partnership comes into this. Because if we go back a few years, CMP had the vision to work with us and others in this sector to work on the PHE Learning Initiative. I think it was the Gordon and Betty Moore Foundation that actually funded all of CMP's work in this, which was really, really important because we were trying to ensure that reproductive health and rights and family planning was framed in a way that made sense to conservationists. So one of the first things we did was come up with a definition of population health and environment. And this is now used by lots of people in the conservation community. So PHE projects, in effect, are in these rural areas where there are the poorest health services. There are conservation issues that are directly impacted by population growth and human actions. And there is a theory that if you were to integrate the health services and the more traditional conservation actions, that you would have a 1 + 1 = 3 effect. So this is where you have multi-sectoral partnerships, they're inclusive and equitable programs, and you integrate actions across sectors. Now, also relevant to the focus of today's session, we worked on developing some theories of change in this learning initiative, and there was one theory of change that was about human health actions and conservation actions in general. And then we did a more complex theory of change that was reproductive health services with conservation actions, as well as 3 specific project theories of change. So we were really pleased that CMP was open to this years ago. And it's exciting to be able to report back in a way on how this has led on to other changes. Perhaps the biggest policy change that we're most proud of is that we're actually in the Global Species Action Plan. So this is the IUCN's policy on how IUCN says that we should reach the goals of the Global Biodiversity Framework. And we feature under target 14, you'll see in 14.5, we're talking about ensuring removals to barriers to family planning. But what was really interesting in this process is that because conservation policies and structures have existed for a long time before there's been more working with the health sector, it's often very hard to find out where you can insert the health actions. So if I'm honest, it doesn't fit very comfortably under target 14, but it fits even more uncomfortably under any other targets. So one of the challenges we have is to start breaking through into policies like this or into CMP learning initiatives, which why that was such a, why we're so pleased CMP were open to it, because these steps with IUCN and CMP are leading onto subsequent steps. Something that Claire's been really involved with is has introduced me and other members of the task force to the process of reviewing the conservation actions classification scheme. And Claire would be able to talk to this, how it was very hard to work out again, where could health actions go? Because the existing structures didn't really allow for health actions. However, another point of pride, I think, for CMP and the others that are involved in this scheme is that the latest draft does actually have a new behavioural change classification on human health services with conservation co-benefits. And it's the kind of reproductive health services that our organisation focuses on. But then also there's a lot of zoonotic infections that can pass between humans and non-human primates and other species. So in that case, vaccinating human populations serves a conservation benefit as well as obviously being the right thing to do for people. So we're starting to see more and more changes in this field. Now, the next conservation action plan that we've been able to influence is the conservation action plan for 10 species of primate. And this was aided by the CMP definition of PHE, the GSAP, and the other things we've mentioned to date. So there's 10 species of primate under this plan, and 6 of them actually refer to reproductive health services as part of the response to the threats to that species. So in the planning process, the conservationists were looking at the threats to each of the species. I've pulled up the golden-bellied mangabey as one example, and bushmeat, pet trade, unsurprising threats to the primate. But in this particular area, when they were looking at the habitat loss was, whilst it was partly driven by deforestation, some of it was also from encroaching human settlements and the need for people to have areas to farm. And of course, when people are having more children than they would choose to have, that leads to having no choices, because, you know, if it would be the same for all of us, wouldn't it? If we had the choice of having hungry families or not, we would do things that were bad for the environment to look after them. But this is actually an example from this plan of how the conservationists involved in this plan looked at the threats to the primate and then how to respond. And then one of them is this large section on responding to public health needs that you can see here. It actually refers to the Margaret Park Trust and the task force that we're involved with. But we're never saying that you should, as conservationists, be providing health services. We wouldn't want doctors and nurses to undertake work conserving primates. And it's the same in reverse. It's all about partnerships, finding the right health partner or the Ministry of Health to work in partnership to deliver the services which are wanted and appropriate. Now, away from just a conservation action plan on merely 10 species, this is the second conservation plan we've been able to change, but it covers all amphibians. And because we'd already got the CMP definition and the theories of change and the GSAP and the primate plan, and we're starting to build a larger collection of policy changes, it became even, not necessarily easier, but there are far more references to reproductive health in the amphibian conservation action plan. And this was like one of the schemes that I thought that was very interesting in the plan that I actually wasn't involved with. But it's very common for people to talk about human population as a driver of biodiversity loss. But when we're in our conservation silo and don't talk to the health sector and are less aware of the number of people who want health services but can't access it, or statistics like 50% of pregnancies in the world are unintended, the 270 million people who would like to get contraception but can't access it, instead of seeing this as a challenge which has no answer, actually does have an answer. And the health sector is very keen to respond to the challenge, if only there was greater support. One of the other calls from the motion a few years ago was that we were to seek, or IUCN was to seek to gain references to reproductive choice in the NBSAPs, the plans under CBD. And this was one of the publications we launched. I'm hoping that our first success will be in the NBSAP for Madagascar. But the point is here, we went through an analysis of 69 NBSAPs or existing NBSAPs in the countries where the health sector believes there are the greatest barriers to family planning. And 64 of those 69 countries had themselves stated that demographic pressures were one of the greatest or the greatest threat to biodiversity in their country. But they hadn't spoken to the health sector. So the health ministry in the same country had made commitments to the international body on family planning, saying of the importance of improving family planning services, but hadn't spoken to the Ministry of Environment when the Environment Ministry wrote its NBSAP and highlighted that demographic pressures were a challenge. So there was a disconnect between thinking something was like a challenge which couldn't actually be responded to. We were hopefully going to be joined by our colleagues from the International Crane Foundation. So to try and highlight how these policy changes can lead to programmatic changes in the real world, I'll introduce a project which has been developed by the Margaret Pike Trust, the International Crane Foundation, and Ragurama Hospital, one of our Ugandan partner hospitals. The project takes place in the wetlands of Ruchiga, as you can see here, with an intact wetland at the bottom of the hill slopes, but then everything from the bottom of the hill slopes up is agricultural land. Cranes nest in intact wetlands and need a large space between their nests. So whilst they can roost outside outside intact wetlands and can feed in agricultural land, the one part of their life cycle where they do need untouched biodiversity is that they need the intact wetlands for nesting. And here you can see cranes feeding in agricultural land. And these are the threats to cranes across East Africa. It's human-crane conflict, or the perception of conflict, just because cranes are so large, they're thought to damage crops as well as eat them. There's obviously the reduced breeding habitat for cranes, and the other issues that you can imagine. But what we did was we went through a process of 6 months of ethnographic research to speak to the community and ask them very open questions about their challenges, not the conservation challenges or the livelihood challenges, but just their challenges. And they were very clear that they could see today the connections between climate change and their health, between climate change and agricultural livelihoods. But they also said that one of the challenges they had was that there was an absence of health services. and that they were all having, or not all, but on average, were having 8 children per woman. And they wanted to have 6 children. And the reason they were having 8 rather than 6 was the absence of health services. So they were calling for health services because of the cultural pressure to hand land onto future generations. And then when subdividing land between more children, it was unproductive. If you look at this map from ICF, the Endangered Wildlife Trust, on the left, it highlights where people live in Uganda, with the darker colors being more dense areas of human population, whereas the map on the right shows where cranes live. And you'll see there's a huge overlap, because cranes are a species that often doesn't live in protected areas. They're in wetlands, they're in agricultural settlements. So traditional conservation, we believe, won't work if you're trying to conserve cranes. You've got to work with communities, because communities are where the cranes live. So we were proud that we then formed this partnership between the organisations. You can see at the bottom of the slide, and it was the very first time that the Darwin Initiative, the UK's flagship biodiversity funding mechanism, funded a conservation project and funded clinical health services. There are now 21 clinics working in this area, which were either closed before or totally unserviced. So there's 50,000 people that are now getting health services because of the connections made between family planning, wanted health services from the community, and the connection with cranes. Although we provide all health services, we don't only provide family planning services. And our theory was that if you add conservation, livelihood, and health action, you would have that PHE impact of 1 + 1 = 3. You'd get greater outcomes. So we developed the project a way where there were 2 halves of the project site. There's the site that we call the parallel site. And if you lived there, you'd have then seen a traditional health intervention, and entirely separately, a traditional conservation intervention. It was like 2 projects happening in parallel. In the integrated communities, we undertook the same services, but everything was integrated. So rather than having community talks that only spoke about health and community talks that only spoke about conservation, there was one set of community talks that spoke about both issues, and importantly, the connections between the two. And the reason we did this is because we wanted to get to the end of the project and establish whether our hypothesis that greater outcomes would be true. So we promoted sustainable farming outside the wetlands. We diversified livelihoods. There was work to provide clean water. Communities were incentivized to live with cranes. There was obviously the health services. And then we get to the end of the first few years of the project, and what have we seen? Well, our theory that you would get greater conservation, health, and gender outcomes from integration has been proved to be correct. There are an awful lot of reasons for this, and there are an awful lot of other examples other than on this slide. But I thought I would pick just a couple of conservation points. So as you can see on the slide, the conservation groups in the integrated areas are saving more money. There's far more people actually joining the groups, and they implemented more conservation work. In the integrated sites, there was a far higher uptake of health services. And in news that we've actually only announced earlier today, and this wasn't within our plan, we were absolutely thrilled to see that women in the integrated sites are dramatically more protected from gender-based violence. And largely, the academics are telling us that's because there is to report gender-based violence, you need to trust your partners. And there is a higher degree of trust in integrated sites because there was ethnographic research done. And the ethnographic research asked, what are your challenges? And our challenges were health services, and you came and provided them. The challenges were climate change, and then the landscape actions are seeking to mitigate the impacts of climate change, providing livelihoods. And we've come along and we've actually listened to the community and responded to a plethora of their challenges. Now, where next? This all started at the beginning of my presentation, talking about our motion that was restricted to reproductive health services. But we're really pleased that the latest draft of the IUCN programme does refer on multiple occasions and significantly to One Health. But One Health approaches are often thought to relate purely to zoonotic infections. There are many definitions of One Health. the main and most important definition does not only refer to zoonotic infections, but it's still what a lot of people think it means. The issue of disease passing between humans and wild species, or also impacting in farm animals. So we don't think that it is correct to only focus on zoonotic infections, and there's a whole host of other human health issues which can be responded to by the conservation community, where we get this 1 + 1 = 3 results. So I'm really excited that there's so many people on this call, because I'm hoping that perhaps tomorrow I might be permitted to share the draft text of our next motion, which is exactly about the focus of today's session on other connections between human and environmental health, and how by working in partnership between the conservation and health sectors, we're actually able to generate greater outcomes for people and the environment. Thank you.
Amazing. Thank you, David. We do have time for Q&A right at the end of all of the presentations, but if anyone has a big glaring comment or question for David that they can't let go of and they'd like to ask now, please feel free to raise your hand or unmute yourself and go ahead. All right, you might be off the hook for the moment, David.
Great presentation, David.
Yeah, it's wonderful to see that our assumption is always that integrated projects are going to be more impactful, but it's wonderful to see quantitative data and evidence actually showing that. So that's really exciting. Alrighty, our next presenter is Dr. Catherine Wahlen. She works for the US Agency for International Development. She is their Natural Resources Officer. So I'm going to share my screen for you, Catherine, and hand straight over to you.
Great, thanks. And I agree, David, that was fabulous. And it's nice to see, I think, that whole set of things. And I think you put us to shame as biodiversity people, because your pictures were beautiful of the biodiversity. So really nice to see that. So you can go ahead to the next slide. Thank you again for inviting USAID to speak today. I'm going to briefly introduce one of our cross-sectoral programs, our Hearth program, and then share some of our health-specific results. So USAID is a major development donor, and I work in our biodiversity sector, but as USAID, we don't just think about biodiversity conservation, and we think about how biodiversity conservation can help us achieve other development goals. And so that means that we're looking to achieve goals in health, governance, women's economic empowerment, and think about how both of those sectors, biodiversity and other sectors, and vice versa, can help us to take a holistic approach to development where we can achieve benefits for both people and the planet. Next slide. So one of the ways in which we do this is through our Hearth program. Hearth stands for Health, Ecosystems, and Agriculture for Resilient and Thriving Societies. A way we like to help people remember it is through the picture above, which is Heart plus Earth. So USAID launched the Hearth activity on December 3rd, 2019, which was 1 week after the index case of COVID-19. So I think we've shifted a lot from the ways in which we're thinking about things then and now. But it has really proved to be a great initiative in terms of thinking about cross-sectoral development solutions. So when we launched Hearth, we called for this co-creation approach where USAID isn't just designing the activities, but we are looking for people to partner with us in the design of them. And this one specifically included both public and private partnerships for advancing sustainable conservation of threatened landscapes and the well-being and prosperity of communities who depend on them. Next slide. Okay, so where we are today, we have 17 Hearth partnerships with a value of over 165 million. One of the things that makes Hearth unique is that all of the awards are required to have at least a one-to-one match with the private sector. So USAID put forward $75 million, and then we were able to leverage over $90 million from the private sector. So together, those investments result in this 165 million 17 partnerships across 15 different countries. And they allow us to work on common goals of advancing progress in conservation, health, water and sanitation, energy, governance, and other development sectors. Next slide, and apologies because I know that's super small. So what I want to do today is talk a little bit about where we are in implementation and learning from our results. So we have these 17 different activities that are connected through the Hearth family, basically. And all of these activities have similar goals and interventions of meeting environment and human development goals. They're based on common theories of change, and they're implemented on similar timescales and with a similar learning agenda. So all of our Hearth activities share a common learning agenda, and we're conducting pretty rigorous monitoring, evaluation, and learning across the entire portfolio with the aim of better understanding what works, where it works, and why it works. And so we're looking across this whole cross-sectoral development, including health. And I think David described how the PHE community talks about 1 + 1 = 3. And that's something that we also say among our Hearth family as well. So in my next couple of slides, I'm going to give a few examples of some of our health outcomes. And I think with the caveat that it's a big portfolio of programs, and I've picked just a couple of things. Elizabeth Dowd, my colleague who is on the call as well, knows this activity really well, so I'm sure she can also jump in. And just noting that it's not just a biodiversity effort at USAID, but really we have colleagues from across the agency who are participating in this, and I'm just sharing some of their and our partners' results. So to ground it, I want to give you an example of one activity. So the USAID ECNA activity works in the Eastern Kafue Nature Landscape, so ECNA, Eastern Kafue Nature Alliance. It works in the largest national park in Zambia, and it's implemented by the Nature Conservancy. It has a number of different strategic approaches that focus on addressing key threats to biodiversity and strengthening natural resource management. The ECNA activity has strengthened governance and supported village land use planning. They help form fisheries co-management areas. They supported climate smart agriculture, and they also built capacity to monitor the results. So a lot of the things on this slide, I think to many of you in the audience, are really not unique if you're familiar with USAID's biodiversity programming. But what makes this activity different is what I'm going to share on the next two slides. Okay, so the additional strategic approach that this activity works on is actually strengthening community maternal and child health, which we heard from David, right, about how important that is in so many of these areas, as well as improving access to clean and safe drinking water. So in addition to its emphasis on natural resource management and governance, ECNA works to train community health workers and partners with the Ministry of Health to connect people to information and to make sure that the people who are surrounding these national parks and game areas have access to increased healthcare. Because we also, in our programming, realize that that is one of the things that the communities struggle with, right? As biodiversity practitioners, we can't just focus on conserving the wildlife. We can't just focus on looking at community patrols, but we also have to make sure that the people who are living in these areas support these areas, and they can only support them if they are healthy, if they have access to good and safe nutrition, to water, to those types of things. So that's really where our thinking is on this. And that has resulted in some great results, not only for biodiversity conservation, but also for health. So as you can see on this slide, we now have more women who are giving birth in a health facility and more newborns who are receiving postnatal care within the first 48 hours of their life. Next slide. So as I mentioned, Hearth is a pretty big portfolio of projects. At the top here, you see some examples from the ECNA activity about access to information on maternal and child health and how that resulted in these additional births at health facilities. But we also have other activities that are achieving different and similar types of health results. So in the DRC, we have an activity that's called the Gorilla Coffee activity. And that is shown here in terms of the number of people. I think we're missing one of the details, but basically they've worked on providing planning services and health planning services to couples. And in the first year in FY23, they provided services to 4 couples. In FY24, they provided services to 640 couples. So as we've gotten going, we've been able to expand our results. Also, in terms of dietary diversity, we are working with communities to improve health, nutrition, and resilience of households around the national park. And so following some work with communities on community gardens and other activities, we were able to increase the household dietary diversity score, which basically looks at, how many nutritious vegetables are you eating? How are you cooking? Those types of things. So some additional results that we're proud of. Then my final slide, in case you're getting worried about all of the things that we would love to share so much, I think. But I just wanted to flag that we also have achieved a lot of results in expanding access to improve water sources for communities. So you learned about the ECNA activity already. Gorilla Coffee is doing something similar. They have and I think the first year they improved access for 22,320 people in terms of access to water. And when they achieved those results, they decided to increase their life of project target. So they're now working towards getting 65,000 people over the life of the project, which is exciting. And we're also working on things like borehole rehabilitation and strengthening and maintenance. So ECNA has done that. We have another activity which is working in Angola that has installed and repaired 87 boreholes in the Upper Okavango region. And they support community health through community-led total sanitation approaches, including constructing community latrines and green school education programs. So I threw a lot at you because I wanted to show some of the breadth of what we're doing. And I want to just caveat that this is just like a very small snapshot of this huge family of programs. So I'm happy to speak later about it. And then just want to close by thanking our implementing partners. They're really the people who have helped us to achieve this results, and we could have never achieved the Hearth portfolio without their great partnership. So noting that I just picked a couple things. And then this slide has our Hearth landing page on biodiversity links, which has our learning agenda. We have a monitoring and evaluation and toolkit, which you can look at. And we also have a One Health info hub. So I haven't used the word One Health too much throughout this presentation, but Hearth really does take a One Health approach. And we have a lot of resources on how we do that, not just through the Hearth portfolio, but through USAID more generally. Thanks.
Brilliant. Thank you, Catherine. Any questions, comments, thoughts for Catherine before we move on?
Catherine, that was a whirlwind and that was great.
Thank you, David. We will, of course, come back to you. Feel free to think about it and pop some questions in the chat, but there'll also be time at the end of the presentations again to ask all of our presenters whatever you like, as long as it's relatively in line with what we're talking about. All right, let me stop sharing. Next up, we have Dr. Sarah Olson. Sarah works for the Wildlife Conservation Society. She is the Director of Health and Research. Sarah, oh, you're already sharing. Perfect. You don't need me. Take it away.
Great. Thank you so much, Claire. And hello, everyone. It's really exciting to be here today. I'll really try to focus on Republic of Congo, but with some background to get there. And this first photo here, I think it just is to show that our work does touch on every continent, although we'll be focusing on Congo. This is an instance in Peru where our government partners were working to address an outbreak of a mass mortality event in Peruvian pelicans, and it turned out to be high-path AI. So our health program at WCS builds on over 100 years of wildlife health expertise. It really started with the care we provided to zoo animals and then grew into this global program. where we're now providing support to over 50 countries, where WCS is on the ground, and also engaging in multilateral activities like the Pandemic Treaty. WCS recognizes that health exists in an intertwined social ecological matrix. Nature and people are not separate, as we heard from in the earlier talks already today. And this means we end up working with local to national actors across the environment, human and domestic animal sectors. And we work across landscapes that are facing diverse health-related threats to elevate the health of all living things using conservation as a primary intervention. And what do I mean by primary intervention or prevention? So my graduate training is actually a mix of public health and environmental research. And this is a continuum of care model really comes from classic public health, at least the right-hand side of it, really focused on social determinants of care. And currently, public health really leaves out what I've circled there in the green boxes. So prevention in the public health mindset really is thinking about actions like seatbelts and reduced smoking. That's more simplistic than it is, but I think the focus is that we're now framing ecological integrity as prevention, given that intact, functional, and resilient ecosystems really provide the foundation for life, health, and the well-being of everything on our planet. So moreover, it's also important to note that health and prevention is an intergenerational responsibility, as each generation is going to inherit the ecological integrity issues of the generation prior. And this holds for things like AMR, persistent organic pollutants like PFAS, as well as pathogens. And I echo David's concern that you don't want One Health to focus on zoonotic issues, although I'm going to be talking about those. But it's really a concern for all of these health considerations. So I am going to focus on pathogen threats for pandemic potential. At WCS Health, we focus on interfaces where spillover can occur, the behaviors and the practices that create those risky interfaces, and then take action on those behaviors and practices with surveillance, research, and ultimately motivating policy change. So in the lower right in the infographic, it shows there are, of course, different pathways for conservation to enhance public health. And I think we've just heard a great example of the maternal healthcare work that's ongoing and reproduction support. But 3 of those pathways have, so those that are in starred have been shown to cost less than 1/20th the value of lives lost each year due to spillover. And it'd be great to start seeing folks add in some of those models, reproductive healthcare as well. But today I'm going to focus on some of those examples from Congo on surveillance, research, and policy. So going back to the mid-2000s, WCS started a collaborative wildlife mortality surveillance program in the northern communities of ROC. And this was a response to Ebola outbreaks in the mid-2000s that were traced back to individuals who had come into contact with wildlife carcasses. And the surveillance also involves rangers who patrol national parks, as well as engagement with forest concessionaires that we work with. I'll mention here for rangers, we're now actually introducing a new standardized health event data collection model that we've already piloted in Southeast Asia, Peru, and starting up in Madagascar as well. That can be used either on SMART, which is a data collection platform that they use in a lot of protected areas, or Earth Ranger, which is kind of coming in maybe in the next year. And then basically the effort starts out with a community or ranger team being visited by our wildlife health outreach team. They bring posters, they bring information about zoonotic diseases, and we have actually an Ebola song now, which is fantastic. And they're told to get in touch if anybody in the community encounters a wildlife carcass. And once we receive a report, a trained team responds and safely collects samples and tests them. We test for Ebola and anthrax, and then we notify the communities of those results. So the work in Republic of Congo falls under our internal initiative, which is called Wild Health Net, which is working to connect those local to national level actors in national wildlife health surveillance program that's connecting the multiple sectors. So working with the existing resources that we have in those sectors. So it's cross-sectoral, and it's supported with training in the necessary skills that's not there, or growing the skills that are already there, and also introducing technology to support the surveillance. And then also making sure that they're appropriately responding to wildlife health events to meet those global standards. So right now we have a lot of global standards over here, but nothing really happening at this level. And that's where Wild Health Net is our approach to kind of support the establishment of wildlife health surveillance. Another example from Congo is some health policies in New Bali and Doki. I think this is really exciting. Nubali Ndoki is a place for great ape tourism. And as we heard earlier today already, pathogens are known to move in both directions, from great apes to people and from people into great apes. So some of their One Health policy objectives are on this slide that they've set for themselves. Includes collecting and reporting information on mammal populations, but embedded in that is maintaining a wildlife disease surveillance reporting network, conducting pathogen surveillance, making sure we know what's moving in the wildlife as well as what's moving in people. More on that in a moment. And then also developing appropriate shared laboratory resources. So minimal resources in these places means that we could think about developing a shared laboratory capacity that meets the needs for human health as well as environmental and domestic animal health. Here in objective 2, working to improve the health. So improving the healthcare, making sure that the workers are getting access to vaccination, regular health checkups, as well as the use of these health passes. So this is like a health pass to make sure that the individual has checked in with the doctor and they're okay, they got the green light to go into the forest. You can see here like folks in the forest that are using disinfection materials before they actually go into a place where the great apes are, washing their hands, etc. And then the last thing here is working to improve the community resilience and disease transmission for the folks that are living in communities in the periphery of the park. So this includes activities of raising awareness on basic health, hygiene, and sanitation. And excited to hear again from David earlier today and thinking about how we can maybe bring some of that approach and population health and environment to this space as well. And then another component is thinking about using just our presence in these communities to develop a human disease surveillance network. We had teams traveling around and outside the park, and they were actually helped identify one of the first Mpox cases in northern Congo earlier last year. So that was really a good connection because we were working so closely with the public health sector that we were able to kind of flag that case and get it reported very quickly. In the research space, again, focusing on those high-risk interfaces, we have this paper in review on the socioeconomic and functional assessment of the live bat value chain in Republic of Congo. There's a great Nat Geo story on this live bat trade where they're catching the bats and they're live, bringing them into the city where they're being sold to people who are purchasing them. The 2 sites are in Weso and down here south in Brazzaville. So key findings are it is an important source of income, and that the trade volume and prices are highest in Brazzaville, which is a concern from a pandemic perspective because we don't want those pathogens in really urban, dense populations. And then the awareness of zoonotic diseases is low among vendors and consumers themselves. So next steps are, continuing to bring in some studies of what are the viral risks and understanding what pathogens are present, both in terms of antibodies and if we can detect any pathogens. And this is being done both in the bats, but also in the wildlife traders, those people involved in the value chain, so we can understand if they've already been exposed to some potentially high-risk pathogens. Other areas of research is just, working on the surveillance, improving surveillance. Historically, sometimes in the past, many, many years ago, it was taking up to 6 months to get one of these carcasses that the community flagged, tested and whether or not there was Ebola or not. From a surveillance perspective, that's terrible because 6 months is too long to wait to know whether a carcass in your backyard has Ebola. So now we've increased, working with our partners, the time to testing is just 2 hours. So we can basically take this kit to the field and get a response, whether it's anthrax or Ebola positive within 2 hours. So that's really helpful and supports public health response as well. So in conclusion, this editorial from January 2023, The Lancet, it's probably one of the most prestigious international journals on public health, and it really drives home the importance of focusing on ecological integrity as primary prevention. The implication of taking a One Health approach is the need to reduce human pressure on the environment, and it's an important medical intervention in itself. And that in the truest sense, and here come back to the problematic word of One Health, it's really a call for ecological and not merely health equity. So to recap, health, again, is a human right. It's a global common good. It's an asset. There's also a need to recognize that's an intergenerational responsibility, as well as a need for interspecies health equity recognition. So I'll leave my contact info up there, but just a fascinating set of panelists have already gone. I'm looking forward to the ones that follow and the discussion as well. So just looking forward to spending some time thinking about this space with you all.
Brilliant. Thank you so much, Sarah. Any quick questions for Sarah before we move on to the final presentation? Okay, I'm sure we'll come back to you, Sarah. Thank you so much. The final presentation today is actually going to be a recording just because of time zones. We've got a recording from Dr. Prishani Vengetas, who is the conservation veterinarian and global One Health coordinator at WWF. So I will share my screen and just shout if the audio doesn't work or something, but hopefully I do this correctly. Okay.
We can't hear it.
Yeah, no.
I can't hear it either. Okay, hang on a sec. Let me figure that out.
We did practice.
Okay.
Claire, does Wordly do lip reading by any chance?
It should actually. All right. Just note, in this presentation, the audio is a little bit off right at the beginning, but it gets a lot better with regards to the image. So it gets better. Okay, this sounds like it's working this time. Let's give this a go.
Thank you so much for inviting me to this call on integrating human health into conservation. Today, we're going to be talking about the interdependence of human, animal, and environmental health. And this isn't just about improving human health by strengthening wildlife and ecosystem resilience. It's about looking at health equitably across all sectors for the benefit of everyone. Okay, so let's get started. A quick blurb about me. My name's Dr. Prishani Vengetas. I've worked with wildlife for almost 15 years. I started in general medicine, zoo medicine, emergency work, and then went on to working with bushfires and wildlife trade, search and rescue. And eventually I found a home with conservation medicine and One Health. And so what is One Health? This is the One Health triad. It represents the connection between humans, animals, and the environment. And there is this broader definition from the World Health Organization, but at its core, One Health is our approach to support the health of humans and animals in the environment that we share. And we can't achieve any one of these entities alone. The well-being of each one of these circles are interdependent. And so we need to address them together and equitably in order to generate resilient health. So One Health is a simple term for what is a complex conservation management necessary to prevent, predict, detect, and to respond to global health threats like the COVID-19 pandemic. Now, what COVID did is it helped us to see that the chances of disease spreading increases the more that humans and wildlife come into contact with each other. Now, land use change and wildlife trade are among the more commonly known causes of increased contact, but climate change, deforestation, and livestock use are also key causes of an increasing interface between humans, animals, and the environment. And it's unsurprising then that with this rising global movement and population expansion, 60% of known infectious disease originate in animals, and 75% of emerging infectious diseases come from animals. But having said that, it is important to also remember that health is not just about infectious disease. It also encompasses pollutants, toxins, mental health, as well as many other aspects. So now we know what One Health is, but let's talk about why poor health is not just a risk to our well-being, but also our pockets. The economic crisis caused by pandemics isn't this abstract concept. It affects us in three main ways. The first is that it increases biodiversity threats like poaching, wildlife trafficking, and forest logging. It erodes protection of parks and vulnerable species, and it also forestalls monitoring and research that makes these impacts visible. The second is that it weakens institutional support for conservation by interrupting funding streams. And the third is that it reduces our own health and resilience, and that reduces our ability to generate an income. But the good news is that investing in One Health and addressing the drivers of disease is 1/20th the cost of responding once a pandemic has emerged. And it has substantial co-benefits that includes climate change and biodiversity loss. It doesn't have to mean developing new programs or projects, but instead complementing existing work that are already primary prevention actions, like better surveillance of health in wildlife projects, or understanding health risks of the wildlife trade, and of course, reducing deforestation and land conversion. And a great example is bovine tuberculosis, or TB. It's a bacterial infection. It infects humans and cattle, as well as wild species like boars and deer and antelope. And it's a serious problem for animals and for human health in many developing countries. The disease is contagious. It can be spread between infected domestic and wild animals, or indirectly by ingestion of contaminated material like undercooked meat or milk from an infected cow. And you can see there are many different arrows here, which signifies many opportunities for the disease to spread. And if we want to create a healthy landscape, it is best to use a multi-pronged approach. And that might be starting with protected areas to decrease human and livestock in the natural environment, oral vaccination of wildlife against disease, surveillance to find out where the disease hotspots are and what wildlife need the most help, of course, vaccination of humans, and educational programs to support their understanding of disease, like how to prevent it by proper cooking of food. And finally, to implement biosecurity measures to decrease the interaction between wildlife and livestock. So you can see generating resilient health in a landscape with TB means implementing health measures in all of these areas, not just one. And another good example is a WWF project in the Congo Basin that is aimed at identifying, preserving, and expanding conservation areas that act as natural barriers for pathogen spillover. Now, there you can see there are many different objectives, multi-pronged approach to this program, but we're going to just focus on one area to deep dive into, which is pathogen early warning, or disease early warning systems. This in itself is a multi-pronged approach, and it is aimed at reducing that high interface that has led to an increased risk of disease transmission between the gorillas and humans, particularly due to ecotourism in the area. The first is disease prevention through biosafety measures and a vaccination campaign for high-risk individuals. It includes annual staff health checks. The second is routine health monitoring, which might include collection of samples from gorillas, like non-invasive feces collection. Also, ecological monitoring from camera trap observations, and screening for diseases. The third is that the team also acts rapidly to respond to veterinary emergencies like that might need immediate necropsy or postmortem for animals found dead. And then they do PCR screening for important diseases like anthrax and Ebola virus. And the fourth is disease and pathogen research program to monitor flies as vectors of disease. Now, also to support the integration of a One Health approach in conservation, WWF developed this report that details our approach to address these anthropogenic and nature-based drivers of infectious disease in terrestrial and freshwater environments. And we did this through guidance on implementing 6 key strategies. And these strategies are landscape immunity, wildlife trade, preventive medicine, pathogen early warning and monitoring, sustainable livestock management, and behavioral change and education. And you can see the results chain here that led to these strategies. Now, they're not designed to be a complete dissertation on the subject. However, they are a good broad overview to help guide implementation and to bring together key knowledge and resources in these areas. They illustrate that there's no one-size-fits-all solution to interdependent health challenges that requires a transdisciplinary, multi-sectoral, and systems thinking approach. Inside the report, you can see practical guidance on applying a One Health approach, the risks associated with a lack of implementation, guiding questions, case studies like the Cameroon case, and additional resources. That includes guidance on mainstreaming gender in One Health and monitoring guidelines with example indicators. And if you haven't already seen the report, you can put your phones up, grab this QR code and download it, or you can grab this slide deck from your teams later on, and the link is embedded in the slides. And lastly, the integration of health into conservation requires adequate policy. At COP16 this year, CBD parties approved a global action plan on biodiversity and health, which outlines very clear actions that can be taken against the global biodiversity framework targets. And it can be included in national targets and action plans, and we strongly support this inclusion. And that's it. Thank you so much. One Health really is about understanding that powerful connection between humans, animals, and the environment that we all share. And by addressing health at this intersection, maybe we can create a healthier and more resilient world for all of us. So thank you so much. Bye-bye.
All right. So that was Dr. Prishani Vengetas. She's not on the call with us at the moment, but a huge thank you to her and WWF for providing that case study. I know we're at the top of the hour, but I'm hoping to steal a few minutes from the CMP business portion of this call to give you all a chance to ask some questions, provide some comments, thoughts related to the presentations you've heard today. So feel free to raise your hand, unmute yourselves, and go ahead. We've got Sarah, David, and Catherine on the call, ready to respond to any questions you might have.
Claire, I think there was a question earlier that's maybe a very quick question that was asking for clarification on whether One Health, Planetary Health, and Hearth are the same. I'm not sure if that was answered in the chat. Scrolling. But if anyone has a quick response to that, maybe there was too much dog barking.
Catherine, that might be a question for you, I wonder.
Yeah, sure. I can take that. I think so. Hearth has a particular acronym. We take a One Health approach, and it is an acronym that does not have sort of the One Health or the PHE in it. So it is a specific acronym to USAID's family of programs. That said, I think we're seeing an evolution of these approaches, right? Hearth, now I'm speaking Hearth and Health, but the Hearth activity learned from some of the earlier population health and environment activities. I think a lot of people know the Health and Harmony and some of those types of activities that really pioneered that population health and environment approach. And as we've grown to think about it and use a One Health approach, that's the term that we have started using more frequently. But I think ultimately we all want the same things, right? We want to improve the health of people, the health of the planet, ecosystems, and achieve strong, sustainable development goals. So that's how I would answer it. Thanks.
I think I'd agree with that, but there's something I'd like to add as well, is that often One Health means different things to different people. So if you've approached One Health as a vet or a conservationist or a healthcare practitioner, you've rightly, because of your job, come to a concept to further an end. And we work with multiple organizations that use One Health in a completely different way. There's a more official definition of One Health that the quadripartites come up with, like the 4 UN bodies. And notwithstanding that, most people in conservation, if you say to them about One Health, they think it means zoonosis and disease you know, to pandemics, and actually we sort of heard that in the presentations, and that's really important. But also, we're trying to advocate in a way, keeping away from some of those definitions and those entrenched feelings, because good health doesn't mean the absence of disease. And if you go and ask people, actual real people, what are your primary health concerns? I mentioned the 270 million women and girls that would like contraception, a really important health issue, and it's not a disease. And IUCN has done a lot of work promoting the connections between gender-based violence and the environment. And of course, if you are a survivor or not a survivor of gender-based violence, your health issue is not a disease. And when you've got human-wildlife conflict, we've got a new site where we're trying to develop a project in Mozambique, and there's a big issues with elephants there. And if you were to ask people what's the biggest threat to your life, they're not going to say they're worried about an emerging pandemic when some of their friends have been killed by elephants. But like, actually, kind of human wildlife conflict isn't really seen to be within One Health, but it is a reality to actual real people. So I think it's really important that we focus to actually follow a human rights approach. You've actually got to look at the health issues that worry actual real people, rather than perhaps like our concern of a future pandemic when someone has HIV and their partner has malaria and they don't have contraception and they've got risks to their lives.
David Wilkie, go ahead.
Yeah, David and Catherine and everyone else, I couldn't agree more. I think one of the challenges that I've seen in many of the communities that I work with, either in Central Africa or Central and South America, is many young women are they're struggling nutritionally, and many women are amenorrheic, and child mortality in some places hideous. In the 1990s, it was 25% of kids in Congo didn't make it to age 5. And so there's this terrible challenge that if you're labor constrained in your family and your whole family's nutritional system food system is based on field labor, having kids is vital, both for you today and you when you're old enough that you need to be looked after. And yet there's so can you talk, Catherine and David and others, can you talk a little bit about that challenge, that the tension that parents have about the number of kids they have and the value of their children?
I think what I'd say to that actually is you've made another point that of another health issue that doesn't really fit within One Health and isn't a disease, and that's nutrition. And a lot of people on this call are involved with projects that would have climate smart livelihoods or alternative and sustainable livelihoods, and that wouldn't be seen as One Health. But better nutritional outcomes is an absolutely fundamental part of health. And I suppose everything you said, I just agree, because everything's really complex. So we do rapid health needs assessments in the communities where we're developing projects, because you've got to provide the health services that people want, rather than the health services that we think we can shoehorn into an existing program. So at our Mozambique site, I mentioned the human wildlife conflict, but actually they came back and said that they needed help so that they could actually have more deliveries, as in pregnancy deliveries, in healthcare facilities. There was an awful lot of water sanitation and health stuff also, which could be good for the environment, but some of that doesn't fit within One Health. And there was a lot of HIV stigma. So it wouldn't be protecting and supporting human rights if you didn't actually provide the wanted health services. But why this is so important to the conservation community is the goodwill effect. So speaking for the International Crane Foundation, our project partner in Uganda, they have said that the project that they work on in Africa with the greatest community support is our project, because they did the research on what are your issues. And when the community said health services, ICF have now got the credit for providing health services. So on our comparative analysis, it's come back that the community are more supportive because they've listened. And an external evaluation said that so we don't even mention Sitatunga, a locally threatened species of antelope, but the poaching of Sitatunga has reduced because the community are more supportive of keeping out of the wetlands and conservation action, because the conservationists actually cared about us and responded to the things we wanted done.
Maybe maybe just to quickly jump in here, David, just expand. I mean, for me, I think One Health does include thinking about ag systems, because we all need to figure out how ag systems make everything sustainable. And we can see the imbalance right now, even in developed countries in the US, where we have this really, high production system, but we also have high path AI that's on the verge of becoming the next global pandemic. I mean, that's just one area of consideration, but I think we need the whole ag as a space that really hasn't been explored within One Health. Even though it hasn't been explored, I still think it falls within this One Health space of thinking about how we do everything on this planet sustainably and keep everybody, well-being and nutrition and all of those things as best as we can and equitably as we can.
Yeah, and I would just add, I think really briefly, recognizing we may have other questions too, but we do have that A in Hearth, which is agriculture. And so USAID's Feed the Future program works on these issues of stunting a lot. David, there's a lot of focus on sort of those first 1,000 days, right? And as I was sort of said at the beginning, right, as one of the biggest biodiversity donors, we have to work on all of these issues, right? So, I mean, it's our responsibility too to share, hey, we're working in these communities, we're working in these areas surrounding national parks, and we need to work with our nutrition colleagues, we need to work with our agriculture colleagues to see how we can get that funding combined with our biodiversity funding, combined with our health funding. And so that's a really big push that we're making, and we're continuing to try to sort of make that case that all of these areas are really important to be integrated together. And it's not easy, and it takes a lot of time and a lot of talking, but I mean, these spaces are good for starting that process.
Any other questions, comments?
I just had a quick question. There was a lot of focus, especially, well, from all of you, but I had written this question down, David, during your first presentation on, women and girls, understandably. But are there any direct actions, or can you describe more of your thinking about how you all work with boys and men with your approaches? And I know I've heard different thoughts from different people about that type of engagement. So would love to hear more.
Yeah. So actually, this is one of the benefits of working across sectors. If this was now a health discussion and purely health, one of the big focal points would be how men are the problem, and how male family members and male partners are one of the barriers to family planning. I mean, just like to such a huge extent, one of the prime issues. So if the health sector was to go to Uganda and do what they call male engagement, how do we try and change the minds of men? That's a big challenge, because how do you do that? If you have a health talk in a community, dumbing down, men aren't going to go. Like traditionally, if you were to have a conservation livelihood talk in a community, women don't go because of the gender stereotyping of who cares about pregnancy and who cares about livelihoods. And that's one of the strengths of this integrated approach, is because there aren't health talks and there aren't conservation livelihood talks. There are just talks. So when everything gets wrapped up in one collective topic, you actually manage to get your health messages to men. So men learn at the risk to their female partner or family members' lives of unhealthily timed and spaced pregnancies. So you can actually remove them as a barrier to family planning. But the only reason they went to the talk was because it wasn't about health. It was about all of the issues in the project as a whole. And I love this example, and then I'll stop talking, but traditionally the International Crane Foundation would have a crane festival, but at our integrated site, we don't do that. It's got to be it's a festival. So we had a pop-up clinic, and rather than the school children and the community singing and dancing and doing drama about cranes and wetlands, it was about the whole project. And in the pop-up clinic had the highest attendance ever in Rachiga. And we had 2 women come to the clinic who were married to the same man, who did not allow them to have contraception, did not allow them to go to the clinic. They ran into the clinic and said, the only reason we can be here is because you were part of a broader conservation festival. And can we please have, well, they didn't call it a long-acting reversible contraception, but that's effectively what they asked for and what they got. And that would never have happened but for working with a conservation organization and a broader project. So you get those gender benefits each way of managing to access men for health and accessing women for conservation livelihoods. So we've got more women on the conservation committees because of this approach as well. So everybody wins.
Thanks so much. And thanks, Catherine, for the additional, and Sarah and everyone for the additional links and information in the chat.
I think we've got time for one more question before we have to, unfortunately, talk about business. So anything else, anyone want to unmute themselves or put up their hand and ask one more question of our panelists? And if not, Catherine, David, Sarah, any last minute comments or additions you'd like to add before we wrap up?
I think I shared it in the link there, but stay tuned. The One Health Task Force got the World Commission on Protected Areas is working on some tools and resources. So please stay tuned. There's an early kind of perspective piece there that has some of the initial outputs. But I was just checking in with the lead today, and there's some really exciting things coming for protected area managers. And I think it'll be useful for folks to think about. I think it is framed around the pathogen lens, but there's a bit broader kind of, I think, approach there that we're thinking of as well in terms of making sure people have access to healthcare as well as in there. So thinking and hoping that's helpful for people in this group as well.
Okay.
Can I add that I would love to share the draft text of an IUCN motion and with this group, and then pester all of the people on this group from WCS and USAID and all of those other IUCN members that can be consultees and co-sponsors.
We just
Absolutely.
love to be
Yes.
pestered.
Excellent.
Please pester away.
David.wilkie@wcs.org. Minutely emails until Congress.
And Elizabeth Doubt from USAID put in USAID's approach to One Health in the chat too. So check that out. And then obviously we're always happy to talk more about Hearth, and hopefully not as quite of a whirlwind as I gave you today. So thanks for having us.
That was great.
Well, a huge thank you again to all of our presenters today. It's been an honor, and we've all learned so much from all of you. So thank you so much for being here. David, especially, thank you for being here so late, just before your holiday. So yeah, a huge thank you to all of you.